Based on my experiences last semester, nobody actually ever read the syllabus because they'd ask me questions like, what are your office hours? It's all in the syllabus. So if you really want to know, the reason you want to read the syllabus, it's the contract between you and me about what this course is about, what we're going to cover, and what the expectations are. Yes, it's long. Actually, the pertinent parts are about 5 pages. The rest of it's just informational, and I've got the stuff for the clinical in there, as well as your eval, so you know what the evals, they shouldn't look any different from last semester. But, so let's start at the beginning. As I said, my name's Bob. I prefer Bob. Please don't carry that over to all the others who prefer professor or doctor if they've earned a doctorate. I've not earned a doctorate, I have a master's. As I mentioned to some earlier on, I've had a rather, interesting career path. Some might say checkered, I don't know. This is my, last I counted, I think it's my 5th career. It might be 6th, I lose count sometimes. So I've been a nurse for 10 years. Prior to that, I was a software engineer for close to 20. And before that, I was a building contractor. Before that, I owned a portrait studio, sold cars for a little while, and I also ran a scuba shop. And I'm a certified scuba instructor. Well, it's lapsed at this point. The reason for all of this stuff, I'm experimenting. I'll see if, recording lectures, I have both the audio and video. If that's of value to people, if you want to go back and say, but Bob, I found right here where you said, it's bad enough when people bring up the Moodle quizzes and say, well, the Moodle quiz said the answer is this. So, I'll take my chances, and if I say something dumb, it's recorded. Actually, I'll probably edit it out. But as you may or may not know, I actually have put up a blog that originally was specific to this course. Now it's sharing a bunch of content for I'm teaching the Pharm 3 class for the seniors, one of the sections. And I don't know if I'll put my clinical stuff up there or not, but I've also got a number of videos that Dr. Fink has put together that I'm going to be posting up there as well. So the difference between, if you go back and look at the stuff that has previously been posted by Dr. Fink, you actually have to download the file, and these files are large. It can take like forever. So they're all going to go up on YouTube now. And so you can, if you want to download them, you can download them from my site. But you can also just YouTube them, which sometimes is a lot easier. And like I said, it's an experiment. Hopefully it's something of use to you. And if you're really curious, you can go back and look at the afternoon lecture and see if I said something different. Did I tell you a lie in the morning and correct it in the afternoon? So that's my real quick who I am. The reason that I got into nursing, I actually applied to nursing school back in 1973. I got waitlisted. I had just graduated from UC. I had a bachelor's in bacteriology. And I applied to UC, so their nursing program, which at that time offered a bachelor's. And they waitlisted me because, partly because I just had gotten a bachelor's, and they, UC doesn't like to award 2 bachelors in a row. I also suspect there may have been some gender issues in there, and that their program really didn't. They thought nurses should be women. So anyway, I went off and did all those other things. When the software industry in the Bay Area exploded or imploded back in 2001, and I went from getting 15 calls a week saying, gee, can you work on this project, to competing with 300 or 400 other people for the same job that paid half as much. I thought maybe I should do something different. And I woke up at 2 a.m. from a dream saying, go to nursing school. So here I am. I went through a semi-merits accelerated master's program. So the 4-year program you're doing, I did in a year. And for what it's worth, they do 240 hours of clinical per semester, not 120. So yeah, basically our clinicals were 3 days a week. So I know how hard this can be. I figure the one advantage of having done that program was when I took the boards 13 months later, I didn't have to remember back 4 years to anything. It was like, gee. just last fall I took that class. So I think it has a reason that may have an impact on why the pass rates for some of those programs are so high. Last I looked, Merit's advanced, their ABSN and ELMS programs sit right around 98, 99% first-time pass rate. We're not doing quite so well at the moment, as you may or may not hear. And that's one of the reasons that they've incorporated the Kaplan integrated review in the program at all levels. So that's new to my syllabus. That's one of the reasons I had to update the syllabus. And that will happen somewhere near the end of the semester. I actually have to schedule a room because it's a proctored exam. And the policy that we established is that it's worth 10% of your grade. And in order to receive that 10%, you actually have to do the mediation. And what I'm going to do, since that was left to each instructor on how mediation would occur, I decided I'm going to build another Moodle quiz that will cover the topics that were in that integrated review. I do not want this to be a negative or feel like a punitive experience for you. The reason that we're doing Kaplan at this level is our first-time test takers have had some struggles recently at the NCLEX, and it's impacting the school, it's impacting the program. So I want to expose you to those questions and NCLEX-style questions. The issue is the way the curriculum has been structured previously did not track well with the way that Kaplan structures their topics. And so if I just put that out there for you to take, you would not do well, because there's stuff in there that you will not have had, or it hasn't really been focused on. And my way to address that, since there was not enough time to actually rewrite all the lectures and rewrite the entire syllabus, instead, you have a lot of reading to do. So I've assigned those reading topics based on what's in that integrated review, so that the goal is that you will do better and come closer to sort of the minimal, I don't want to call it a passing grade. Kaplan's statistics indicate that if you do 60, in the 60th percentile or better, you're right on track. So with that, with that program, if you only get 63%, or you're above the 60th percentile, which probably most of you are not being that low, you're doing really well. So it's like a 94% chance of passing the NCLEX. The challenge for me and for you, I want you to be exceptional nurses. But you have to pass the NCLEX to do that. And I don't want to teach to the test. I want to teach to nursing practice. So I'm putting it on you to do the reading, and I will give you lots of NCLEX style questions, so that when you take the NCLEX, hopefully that's a one-time event, you're done, and you can go out and be that great nurse. I have all these things flying through my mind, and some of them are not landing. So if I wander a bit, please bear with me, or if I say something and you're not clear, this is to be an interactive class. I will ask you questions, and I hope you'll ask me. So the goal with the Kaplan stuff is just that you have a lot of NCLEX style questions. As you noticed, if you worked your way through the review, I do incorporate the rationales with those. If you had to explain to a friend who's never seen an NCLEX test, how would you say in a sentence why it is so different from anything that you have taken before? Sam, since I remember your name.
Well, I know what the NCLEX style question is usually 2 right answers, and then
right. Have you ever taken
better answers?
Multiple choice tests before where you had 2 or 3 correct answers?
Yes.
Yeah.
SAT is basically
the SAT.
strategize.
That's more an NCLEX style. But in school, did you ever see? Yeah, it was like, I can eliminate those 2, and now it's down to these 2. So yeah, the challenge here is to be able to figure out which is the most correct in that given situation. Part of the strategy is don't read things into the question. Go with just what's there. Anybody know what the purpose of the NCLEX is and why that's the bar that you have to pass to start practicing?
To be able to think critically.
Actually, no. It doesn't focus on critical thinking at all. In fact, being a really good critical thinker will not help you pass that exam.
Well, like, are you talking about like what NCLEX stands for, like the national?
No, it's not. No. Was it? Why do they give nurses an NCLEX style exam before they let them practice? Chanel. Oh, she was thinking about something else.
No, I'm reading.
It went right over her head. Any of you see
That's
Galaxy?
Totally said. I have a question about that. I was reading what you. I listened to what you said about the Kaplan thing and reading what's in the syllabus for the test. So that's a sit down in class exam.
Proctor.
Is how we do on it the points that matter, or is it the fact that we do it and do the remediation?
Yes, that you do it and do the remediation.
So it's the fact that you do it, not necessarily that I got.
I'm not grading you on what you get on the exam. I'm awarding you the points after you do the remediation. If you don't do the remediation, you lose 10% of your grade.
Okay, so it's just completing.
I mean, even if you get in the 10th percentile, God, forget it. After you do the remediation, you get your 10%.
Okay.
So back to what is the purpose of the NCLEX for a new nurse entering practice? What is it supposed to establish?
Patient safety.
There you go. So the NCLEX is not about, can you figure out how to titrate a drug in the ICU? The NCLEX is about the first time you walk onto a unit with your RN. Are you going to kill any of your patients? That's what the intent is to prevent. Any of you remember that strike about 5 years ago where the patient was killed by a nurse at Alta Bates? Ring a bell for anybody?
I feel like there were so many of those kinds of things.
Actually, there's not that many.
Overdose.
For what it's worth.
Or what? Which one was that?
This was a nurse who was a traveler, hired, came from out of state, who crushed up vitamins and put them in the IV. And the patient didn't survive. We want to make sure you don't make those kinds of mistakes. Okay? To me, I'm like, how could you even think to do that? I mean, where did this person come from? What planet were they on? So the NCLEX is about patient safety. It's actually not really about critical thinking. It's about knowing the basic knowledge of, oh yeah, my patient's on DIG and we're giving him Lasix. Why is that an issue? Since I don't know your name, tell me. What are the issues with digitalis? Tell me your name first.
Diego.
Yes. Diego. Do you know anything from what you've read and from your last semester why digitalis and I just gave the answer away. Lasix would be an issue.
Is my potassium levels crapping?
Yeah, what happens when your potassium's out of whack when you're on digitalis? Mm-hmm. So those are the kinds of questions that show up in the NCLEX. They're about that you facing a patient, getting orders for things to do, can look at those orders and say, does this make sense? I spoke about this, and I also was invited to take one of the sections of Farm 3. So I'm doing the morning section, so now I have to get up at 5 on Wednesdays. Yeah, as opposed to getting up at 4 on Saturdays. It happened about 7 years ago. And it was right with the beginnings of the introduction of electronic health records in the hospital and for patient care. And I was a trainer actually for Kaiser when they first went live with Epic up at South Sacramento 9 years ago. I went up there for 6 months to train the floor staff on how to use the system. So patients in the hospital, in the intensive care, patients bucking at the vent. Any of you ever heard that term? Bucking the vent? You'll hear it when you get into critical care, if you go down that path. So if somebody's on a ventilator, you all know what a ventilator is, right? Okay. Bucking the vent is when they are not breathing in synchrony with the machine that is trying to breathe for them. Particularly if somebody is not sedated, they can do this. I would really struggle if I was on a vent. I actually have a large tidal capacity, and I like to move a lot of air, and everything's... So if you put me on a vent and cut the diameter in half, which reduces the airflow by a factor of 4, I'm going to feel like I'm breathing through a darn straw, right? So I might be trying to get, and the machine's going to be alarming, and there's a lot of work in breathing involved. What happens when you increase your work of breathing? What does it do to your physiology? Tell them your name.
Manny?
Manny?
Yeah.
So what happens when you increase the work of breathing, physiologically?
Your heart rate probably increases, right?
Probably. Why? What's going on to increase the heart rate?
You're trying to keep the oxygen flow running
I mean,
along.
what's the body doing mechanically to do that?
Compensating.
Your
Mechanically. Aren't you using like a lot of muscles?
Accessory.
And muscles make what when they work? What's the byproduct?
Lactic acid.
Yes! They burn oxygen, and if there's not enough oxygen in the blood, they go down that other pathway and they make lactic acid instead of just CO2. Even if they're just making CO2. So, a patient who's bucking the vent, who's in the intensive care, probably is not really in a good condition to be making their heart work twice as hard. Maybe they're because they already have an MI. They don't have that capacity. They're already running at 100% of capacity. They can't go past the red line because their heart's just going to say, I'm out of here. So, back to the story. Patients bucking the vent. Now you know what bucking the vent means. You'll probably remember that for the rest of your lives. ICU nurse calls up the doctor. Doctor's in the clinic sitting, at the computer, has a couple of patients up. Says, Mr. Jones is bucking the vent. Can we get something? You'll find that when you guys do your ICU rotation that you will occasionally have patients that are on drugs like propofol or Versed, fentanyl. Those are all either sedatives or anxiolytics, or they're potent drugs and they can change your level of consciousness and affect your breathing. But one of the other drugs they will use occasionally is something like pancuronium or vecuronium. Anybody in your just random wanderings ever run across drugs with those kinds of names? You ever hear of curare? I saw a nod. Tell me your name.
Logan?
Logan. So what does curare do?
All I know is it's a poison, and I think it causes paralysis.
Yeah, it totally paralyzes every voluntary muscle in your body. You can't close your eyes. You can't move a finger. You can't breathe. So you can't buck the vent. By the way, if you ever have a patient on pancuronium or Vec, they have to be sedated because it is a terrifying experience. I mean, to be totally, paralyzed. I think they can move their eyes, but they can't. I know they can't blink. So they also need to tape their eyes to make sure that they don't, do damage. So this guy's bucking the vent, and the doctor orders, I don't remember, pancuronium, vecuronium, one of those. Enters it into the electronic health record from the clinic. Shows up in the pharmacy down in the hospital, and the resident pharmacist looks at it and says, "Oh yeah, okay, that makes sense. It's reads the reason for it, and says, yeah, it's a high alert drug. It's going to require 2 signatures, but he okays it, or she does." The pharmacy takes it to the floor. Takes it to the floor where they don't have any ventilators. It's a med-surg floor, not the intensive care. Hands it to the nurse, who has this bag now that says, high alert drug. And that nurse takes the bag, says, I got an IV to hang, and it's high alert, so he or she, they get their pump set up, get all their IV ready to go, and he gets another nurse to come in, and they sign off on this high alert medication. Hangs the bag, and he walks out of the room. I shouldn't say she, because I don't know if it was male or female. And walking down the hall, the patient calls out as he's collapsing to the floor. So they call a rapid response, and they were able to resuscitate him, save him. And the doctor says, so what, well, what do you think? Then we'll be asked this if you're the primary nurse. What do you think happened? And the nurse said, well, maybe it was that drug that we just hung. So the nurse that hung the bag and the nurse that signed off on it didn't actually know what it did, even though it was a high alert drug. Had that patient not been able to call out, he would have been dead in 5 minutes. That would have been it. And the way this happened was the doctor had 2 records open at the same time, ordered it for the wrong patient. Now there's actually a whole chain of events here because it went to the pharmacy and the pharmacist okayed it on a patient who wasn't ventilated. It went through through the pharmacy tech who went to a floor that had no ventilators. And of course then it went to the nurse who hung it. So all of those eyes along the way bear some responsibility for how that got there. And that's where you get into root cause analysis and stuff like that. So it's possible in an electronic health record to send the wrong drug to the wrong patient and kill them. And who is the one that administers the drug?
The nurse.
So who's responsible for making sure that really makes sense? That's your job. That's the influx. Okay, now I really wandered off in the middle of nowhere there. So let's, shall I look at, do I need to put the syllabus up on screen? Do we need to read through it line by line? Oh, good. So, as I mentioned, there's, in the syllabus you'll find there are 3 midterms, there's the final, and then there is, of course, this integrated review, all of which count towards your grade. And there will be 10 quizzes that are focused on the reading. And those quizzes will have a deadline before lecture. So that hopefully you will have done the reading before you come to class and before you take the exam. They will be pretty much identical to what you saw in terms of format. They'll be little quizzes. They will have their rationales with them. They're 5 points each. There may be 10 to 20 questions for those 5 points. Depends on how hard I want to work or how important I think the topic is. But my goal is that you are well prepared, not only for the Kaplan review, but also for the final. Questions?
Sorry, so when do those go up? Like, do you put them up so we have like a week or
You'll have a week.
Saturday?
I'm behind schedule, which is, I think, the way I spent my nursing career. You'll have hopefully a week or so to work on each one. And some of them, if you haven't seen it yet, some of those weeks have a lot of reading, where I've just basically assigned the entire chapter. I did talk in my syllabus about how to read your assignments, and this actually was a hint from my physiology teacher when I was going to Napa College at Napa JC to pick up my prereqs. His suggestion, which I used, and it worked for me. It may not work for you, I don't know. Chapter. 30, 40 pages of fine print with all this stuff in it, lots of things to remember. I'd read, he suggested, and I went with this, read the topic headings and read the first paragraph of each topic. Then go back and read all the sidebars and text boxes and tables. And then on the third time through, read the things that either you really didn't understand or that you thought were really interesting. So it's not my expectation you will read the entire chapter word for word and know it all. My expectation is you will read it, get the major information out of it, and hopefully that will help prepare you for the integrated review on my final. Yeah. Please tell me your name.
Mia.
Mia.
Will you be highlighting online for the ebook?
Highlighting.
Highlighting the book on the ebook version. Some teachers highlight the book.
Well, when I'm assigning an entire chapter, you guys are grown-ups. Look at the topics, what we're talking about, and I'm going to trust you to pick what you think is appropriate. Really, highlighting, from my perspective, tells you not to look at the other things. I'd rather you didn't do that. I'd rather you go through and find out what appeals to you, what you think is interesting, and if it's relevant to the specific topic for that week, you already know what the topic for that week is. If it's pneumonia or respiratory problems, then you probably want to know things like, blood gases and things that are related to that. And that's going to be in fluid and electrolyte balance stuff. So no, I'm not gonna highlight for you because actually I've already put like 100 hours putting this stuff together in the last week and a half. And I just, personally, I hate highlighting for myself because I find it distracting. Yeah, pick the topics you think are important. And if it's not working for you, come talk to me. Well, you know. My office hours. I used to offer between 8 and 9, but now I'm teaching 8 and 9. So on Wednesdays I'm here. I'll talk with you at lunch, and then I've got the afternoon lecture, and after 4 o'clock I'm here until 6. I'm here on many Fridays for faculty meetings, and so usually after 1 o'clock. Other Fridays I may or may not come on campus, but I am certainly available by phone, email, text. I have published my cell phone. If you need to talk to me when I'm at home, I will probably give you my home phone at that point because I have poor cell reception. I get all my text messages, but actually having a conversation on my cell phone is kind of a nightmare. It drops and doesn't, anyway. Questions? Do you guys have questions? Ask me a lot. I hope you will ask lots of questions. I'm sorry about Moodle. I found that extremely frustrating over the weekend, as I'm sure you did too. Having been a software engineer for like 20 years, I have strong opinions about systems that aren't up for faculty and staff, but I don't work for them, so all I can do is complain. I'm open to questions.
So, really quick, I'm looking at these group presentations.
Oh,
that
yeah.
Start next week, it looks like.
I mean, the group presentations that I forgot to print out the sheet that says sign up.
So, you want us to form a 10-minute short play or movie, so that's not something we can do in class. Like, we can't act out the
Well, I tell you, people,
here, or-
you can act out the scenario here.
Okay, and so it doesn't have to be a video that we bring in?
Oh, God, no.
Okay,
No, this isn't a video production course.
okay, perfect, but I didn't know.
No. I like creativity. Last semester, I think half of them used the Jeopardy approach. I would hope that we have fewer this time. I like Jeopardy. I thought it was useful the first couple of times. By the time we got to the 5th one, I was getting like, let's be more creative here. And actually, thanks for reminding me. I am toying with the idea of basically either randomly or letting you select among yourselves. I found, and research says, study groups work. Now we got close to 50 in total in the class, 48. I would like to see you guys, let's see, there's, how many people are here? I don't know. What do we have, like 24 in here? I can either assign you to groups of more or less 5, or you can pick groups of 5. And you can use those same groups for presentations. I forgot to bring a sign-up sheet. No, I didn't. I forgot to print it out. But what are your thoughts? What do you think about working together?
I mean, I
Collaborating.
personally like doing it with people I know, because then I can call them, I already have their number, and we already know how
Okay.
we work together or what.
Well then,
I just want to be clear on what the assignment is, so.
the assignment is basically to go research something and come present it to the class in a creative way.
Okay.
And you have like 10 to
Based
15 minutes to stand up here and explain to everybody else or ask everybody else about those topics.
on- Okay, and the topic is whatever, so cancer patient needs a blood transfusion.
That's your case,
So that
your
would be-
scenario.
Okay, that's our scenario that we go with. Okay,
I apologize for not having the sign-up sheet.
that's fine.
So it would basically be, in a sense, us performing a teaching process of exactly how we would do that, so people walk out and have a better understanding of the idea.
Yeah, you're teaching.
So you could
You're the
basically
teacher.
have like just a presentation of it. We don't need to go crazy with like PowerPoints and stuff like that. You can literally just stand up and do an example.
Yes, but be creative, make it enjoyable, make it memorable. So if you just stand up here and be a talking head like I'm doing right now, I actually, if you look in the syllabus, you do get graded in creativity. And there was another hand over here.
Oh, no, that's stretching.
Oh,
So you can make a video?
yes. Maybe I should teach this other class on sports video stuff. Yes, okay.
Okay, so in the syllabus, on the different days of the presentations, there are some that have 2.
That's because of the morning and afternoon. Or you,
Okay,
or you have 2 scenarios to pick from.
that day, okay.
Pick one. I could even have 2 groups present that day. I don't think I ever did that.
And next class, it says we have a dosage calculation quiz.
Yes.
How long is that going to be? Is it going to be 10 questions like the
More or less.
example you have?
Mhm.
Those are timed, right?
No, not really.
Were those timed? I can't remember. For farm they were, but not.
I think only the
From my
informal-
perspective, you know, it shouldn't take you more than 10 minutes, but, you know, it'll take what it
But
takes.
it will be essentially like what you have in the syllabus. So if we prepare with that and we feel
Sure.
comfortable with
Actually, I thought if I can find the time in the next couple of days, I thought I'd actually put together a Moodle version of the Metcalcs so that you can read the questions, come up with an answer, and get a rationale. But yeah, working these questions is not a bad example. What is it about nursing and net math that makes it so difficult? No, I'm serious. This is math that anybody else in any other job would say, oh, yeah, it's just arithmetic.
I think
I think
metric
we're just
system.
a little bit
Yeah,
worried.
but metric is all decimal instead of quarter and half and thirds and 15ths.
I think
So all the material that's on here is nothing else than what's on here. Like we won't have to grab our resources and learn something else that we haven't learned yet.
For a med calc quiz,
Yeah.
no, you just read the question and answer it. And do the right math. It's a math word problem. Mr. Jones has to get 15 milligrams of digoxin. Tablets come in 50 milligram. How much will you give him?
I think what she's asking is we haven't learned exactly how to do all. We haven't been taught yet because we only had one farm of how to do a lot
Do you
of
know how to
IT
multiply
stuff.
and divide? Do you know how to add and subtract?
I don't do math.
Then you better not be a nurse because you have to. I'm sorry. I mean, you will be giving drugs that can kill people if the dosage is wrong.
That's what
You do have to know how to do that. And you have to know how to do it well enough that when you use your calculator, that when he gives you an answer because you inserted a 10 where it should have been a 0.1, and you're going to give 100 times the dose, you want to be able to look at that and say, that doesn't make sense to me. So I'm not actually very forgiving in that regard. This math is not hard. I mean, do you balance your checkbook?
I don't keep one.
Oh, well, okay.
I don't use stuff.
You don't use checks, neither do I, actually. I'm all electronic at this point because I was such a bad check writer. This is actually really important. And frankly, you will never work in a hospital that doesn't give you a med math exam as terms of employment. Every hospital does this. And if you don't pass the test, you don't have a job. So it's not just for this class, it's your entire career. And it matters. The farm class just saying, well, we get really freaked out because if we make a mistake, you kill the patient. So I don't actually want to increase that anxiety. But I do want, if you need math tutoring, if you need help with how to set these problems up, as far as math gets, it's pretty much, nursing math is about as easy as it gets. We rarely do things with body surface area and doing square roots of stuff. It's extremely rare. In fact, at this point, even in the hospital, almost everything's automated. There's calculators, the pumps already know then all this stuff. But you still need to know because there may be the day where you're hanging a bag and there's no pump, there's no electricity, and you have to figure out the dose. And you have to count drops, and you have to figure out how many drops per minute that patient has to get the right dose over an hour. So it is actually important. I'm sorry, I was a little hard on you, I apologize. That wasn't appropriate. But, if we need to work on this stuff together, I'm happy to sit down and work on it. I will admit, at times I struggle because I do most of the stuff in my head so immediately that I struggle with trying to set up the problems the right way. I just look at them and it's like, oh yeah, it's that.
Do you allow questions during tests or quizzes?
Well, I won't answer the question, but yes, I do.
But
If you
will
come up
clarify. We've had teachers in the past that you can't ask any
no, walk up
questions.
to me and ask me, and
Okay.
if you're not asking me to answer the
Yeah.
question. If you're looking for clarification, sure, I'll give you contact.
Okay.
I'm not here to make life miserable for you. I know that was a hard weekend, and that was not an easy review. I know that. But when I was looking at those questions, I was thinking, how would I do on this test? I had the advantage of having looked them up, but this is, nursing is not easy.
I had a question on something else when we're done.
Ask it.
The concept maps. 'Cause I see
Oh, I will
that's
explain
coming
concept maps,
up
yes.
too. Okay, so we'll go over that as well.
Actually, I'll show you one of them this morning.
Awesome. Okay.
Sort of a preliminary, real quick, what's the concept map about? I actually found them useful, and I got to the point where I was able to kind of do them in my head. To me, pathophysiology is the underlying structure for all of this as a nurse. And if you know what's going on with that person physiologically, you can make decisions that either guide them down that path or change the path.
So our first one's in class, and then after that, they're due.
I will give you case studies, and last semester I gave people the options of, drawing them or whatever and taking pictures. I'm going to actually ask you to try and use Spider Scribe, which I'll give you all the references are there. It's a graphical, online, web-based system for doing content maps.
And you fill it out and then print it and bring it in.
You can just email me,
Or
and
email
you
it.
say, hey, share this with Bob.
Okay.
That way I know you've done it. And again, I do actually look at them for the elements that they need to have in them in terms of did you incorporate this, and this. Ultimately, the goal with the concept map is to get you to the point of deciding what is the most important thing for my patient today. I am known for repeating this ad nauseum. What's going to kill my patient in the next 8 hours? What could kill my patient? Is it their heart? Is it their blood pressure? Is it their potassium imbalance? Is it the bleed? Or is it the potential for this? And if I walk into the room, what would I be looking for to tell me that something bad is going on? Or great, not good. And when I ask questions, particularly my clinical, but when I ask as a group as well, what would you be looking for? I'm actually not saying, oh, you should call the lab and have them, come up and draw a lab and see what their blood sugar is. How do you assess that patient when you walk in? Every time you walk into the room, you're assessing a patient, or should be. You're assessing the room and the patient. Room and the patient. You walk in, how do they look? How's their mentation? Are they, do they look good? Do they make sense when they answer questions? What is one of the earliest symptoms of hypoxia? Tell me your name again. Next one.
Jade. Jade.
Jade? Okay.
Early symptoms?
Yeah, what's an early hint that when you walk into the room, and I'm not talking about looking at the monitor and seeing an 84% on the machine, what might give you a hint with a patient that something's going on that's not right in terms of their breathing?
Cyanosis?
That's actually a late sign.
Okay.
Okay, that's a good answer. But if they're starting to turn blue, we're kind of getting down the path there. Sure.
Confusion. Confusion.
Good.
Increased respiratory rate.
Not always exhibited that way. So you get confusion's one, and
Agitation?
anxiety, agitation, confusion. So the early symptoms in particular are like anxiety and confusion. The brain's just not working well, and they don't feel good, and they don't know why. So those are the subtle things that the patient has pneumonia. They're walking in the room. I'm looking to see how their mentation is. That's part of the assessment of just walking in the room and talking to them for a second. Do their answers make sense? Do they make sense in the morning and they're not making sense now? If you think that way, you will be a hell of a nurse. Okay, more questions since I've forgotten where I am at the moment. I'm rambling on.
Okay, for the Med-Calc quiz, just going back real fast. We have to get a 90% or higher. Is that going to be a part of our grading class or?
No, it just means you don't get to do clinical. If you don't do clinical, you don't.
Oh, I mean, I would love it to be part of the grade because I.
Sorry. No, there's no score. There's just
Okay, just
pass
fine.
fail.
Okay, cool.
And if you don't, if you don't pass it in class, depending on the timing of your clinical, it will probably be handed off to your clinical instructor for them to retest you, because you cannot pass meds until you have passed that. And if you don't pass on the third attempt, I don't know that this has happened recently, but if you don't pass on the third attempt, you're not going to pass the course. You'll have to do a reset. So again, if you feel like you need, some assistance with math and stuff, hit the learning center or talk to me, email me, whatever. I tend actually not to be quite so hard on people as I did today. I apologize. Other questions? Anybody need to use the bathroom?
Do we take a break during this class, like a midway?
We will, actually, we're probably coming up on a break now, and then also, you're all grown-ups. If you need to run out for a second, run out. I was in the vegetable garden last semester. And so, the doors at the back of the room, it wasn't quite so obvious when you got them walk out. But you're not going to bother me if you get up and go take care of what you need to take care of. And frankly, how many of you actually know nurses well?
Like no person.
Oh, like your mother or a friend or whatever. Okay. How many of you ever heard, oh, what a shift. I didn't come to get to the bathroom till the end of the shift. You've heard that? So, are you all familiar with Maslow's hierarchy of needs? Where would that be in that little pyramid? Like right at the bottom, right? So if you're not taking care of yourself, how the heck can you take care of that patient? I don't know about you, I cannot think straight when I have to pee. When the bladder is really full, it's like, oh my God. So, do that. What about taking a break for lunch, or dinner, depending on the evening shifts? Have you heard about, I never got to eat? Isn't that in the same regard? I mean, that's also the same place there in Maslow. It's like, you need to eat, you need to go to the bathroom, you need, shelter. So, nurses are really bad at taking care of themselves. Don't start here. I will yell at my clinical students if I hear that they went the whole shift without taking their dinner break. I don't know. How many of you are in my clinical this tomorrow? 3? Okay. So typically, I don't actually, I don't support everybody taking a break at once. I know some instructors do that because then they figure it's their break too, so they don't have to worry about phone calls and stuff during the break. I actually encourage you to take your breaks with the nurse you're working with. When they take a break, you take a break. Now, if they're not going to take a break, then you need to take your own break, and you clear it with them. How many times do you give a report during your shift? Over here somewhere. Who? Tell me your name. The blonde.
Oh, Morgan.
Morgan.
Yeah.
Okay. I'm sorry. So, how many times will you give a report to your buddy nurse during your shift?
Like my cohort nurse or my...
Yeah, the one you're working with.
Oh.
Here. How many? 10 minutes, but
Oh, I know.
looks like you're all back. So, tie up the conversations, and we'll move a little further forward here. Yeah, okay. So first off, I'm going to just tell you where the blog is, where my intent is to post videos, audios, or maybe student productions. In fact, I was contacted by somebody over the weekend saying that one of the public TV stations is looking for educational content from the schools and stuff. Maybe you do a great video and we'll put it up there.
That's you.
I actually have my own YouTube channel, which is no big deal. But if you want to post something on YouTube, let me know. No porn. But
Definitely have one.
oh, please. I was able to bring it up in the other room. There it is. Yeah, that worked. That's good. Well, if I can't bring it up, then who knows? Well, I got Google. That's a start.
So what did we
My
decide on
God.
next week for group presentation, or sign up, or we skip it next week?
Worst case scenario is it may get put off a week.
Okay, so that's what's gonna happen.
Probably. You know, we can deal with it, right?
I'm totally cool.
We're-
with it.
we
I just
have to-
wanted to
we
make
have to
sure
be
we're all on the
flexible,
same
right?
page.
Since I didn't bring in the sign-up sheets and you don't have time to do stuff, I'll have to live with the consequences. So anyway, I've got this, I do have this site up there that I've put together for you guys. You'll also find there's going to be some other stuff up there from some of the other stuff I'm doing, so it's not completely devoted to you. So like this is one of Dr. Fink's videos on how to set up a chest drainage system. So that's the intent. And we'll see if it, you'll be able to tell me at the end of the semester whether or not it was worth the effort. Whatever. I forget I'm hooked up to things. Used to happen in the ICU too. Nothing like tripping over the lines for a CVDH machine and having an alarm and shut down and those kinds of things. I'm just going to cut this down a little bit. Some noise out there. Okay, so there is the website. If you would like to author something to put up there, if you feel like you have something to share that you think the rest of the world should know about nursing or your class, I will happily post that for you. Unless you're abusing me. But aside from that. So I mentioned the concept map stuff. Let's see if I can get to that website. There we go. Oh yeah, this is really...
So what if we hate doing concept maps like this with the arrows and all that? We're just gonna be forced to do it on this?
I hate to tell you, but yeah. No, I don't want 100%, I want 45%. It looks like our connection via the school here is just a little bit of a problem. All right, well, since I can't get this to reduce size. So basically in a concept map, at least, these are sort of like the minimal requirements here. I have a patient who came in, she'd been in previously to the ED, got nebulizer for her asthma, went home, and then started having real problems breathing. She's a 35-year-old female. She was, what's BIVA? Yeah, what's BIVA?
Brought in by something.
Your robot
Ambulance.
ambulance, there you go. What's a GSW?
Well, how do we use it? How are you?
Patient admitted for GSW. Gunshot wound. NVA.
Motor vehicle accident.
You got it. See, you're only, we're doing all great. Excellent. So she was sent to the ED, came into the ED, couldn't breathe, and went to the ICU. You're the ICU nurse, and here's the information that you have available to you. She's having to sit upright and using her accessory muscles to breathe. She talks in 1 to 3 word sentences. There's a hint about, again, it gets back to what can you assess with the patient in the moment. Can't talk in a paragraph that says, my name is Janelle. So that's how you know that they got some issues, at least with breathing. You can hear the wheezes. You don't hear any air moving in the lower lobes when you auscultate. You know what auscultate is, right? Listen with the stethoscope. Okay, good. Heart rate's 126. Why would the heart be? Why would the heart rate be elevated? Manny, since I remember your name, why would somebody who has a respiratory rate of 34, is wheezing, and no air moving in their lower lobes, why would their heart rate be 126?
Respiratory rate of 34. They're not using their accessory muscles?
They're using their accessory muscles too.
Why? Circulating oxygen?
Okay, so why does somebody use their accessory muscles? They're not moving enough air, right?
Yeah.
So why would they have an elevated heart rate?
They need to get blood around. Their body's trying to pump everything throughout the body.
Trying to compensate.
Yeah.
The heart says, I'm not getting enough oxygen to the rest of the body. How do I fix that? I move the blood faster. Oh, and by the way, I've got all these muscles that are working really hard and they're making a lot of CO2. Therefore, I have to work even faster. But, oh, by the way, I don't have any oxygen either. Where is this going to lead? What's going to happen to the heart? She's young and healthy. She could probably tolerate it. If they're 80, what happens?
Heart failure.
Yeah, they have an MI. They might die. Do people die from asthma?
Yes.
All the time, yeah. It's still a fatal situation. So you get this patient, you're in the ICU, and your orders are, start an IV with a normal saline. The labs have been ordered, so you don't actually know her lab values yet. She's on a continuous pulse ox. There's a telemonitor, so you can watch the heart. Hopefully, you can get the heart rate down, and you're going to do an assessment every 4 hours, which in the ICU you do. That's standard, actually. You do a full assessment every 4 hours of your patient. You record your vitals every hour. Eyes and O's, at least every hour, usually. So you look at your orders and your priorities. Well, these are my priorities. When I say priorities, again, it gets back to what do I need to be doing to make sure that this patient survives my shift? So, oxygen, she's not moving any air, so we need to enrich the oxygen she's breathing so that we can help sort of compensate for that missing, gas that's in the atmosphere. You got that, Lorenz? Because I figured it's driving you crazy too. We'll eventually probably start using this fan, especially as it gets warmer and warmer. So in your orders, you're going to read something like keep, O2 sats greater than 90%. When somebody is somewhat cyanotic and hypoxic, are the pulse oximeters accurate? Do the numbers they report, are they correct? What are they dependent on to work?
They put the pulse ox on their finger, so don't they need to have
Peripheral circulation, yeah.
Yeah.
If there's no blood flow in there, it doesn't tell you what's going on. What are the alternate? Any of you have to place pulse oximeters in alternate sites? What else? Where else can you put one? Ear, bridge of the nose. Yeah, look for those warm spots that are kind of pink. Don't find the blue ones; they're not good. But the only way you can really tell what's going on with their oxygenation is with a blood gas, an ABG, arterial blood gas. That will tell you what's going on. Everything else is an indicator. It's sort of like, is blood pressure a direct measurement with a cuff? Is that considered a direct measurement? I saw a couple of heads going like this.
Is a blood pressure cuff a direct?
Is that a direct measurement of your blood pressure?
I mean, they're not always accurate, so.
So the only way you can get a direct measurement of the blood pressure is to put an arterial line in, so that it actually has a pressure sensor transducer on it that actually reads the actual pressure. How does a blood pressure cuff work? How does it read your blood pressure? Do you know?
Squeezes the arm and then it.
But how does it know what the pressure is?
Well, we read it.
How does it read it?
Well, it cuts off the supply, and then the force that passes through does it loosens to let it go through. That's
But how does it detect that when the blood flow starts? Most of them are acoustic, just like you. They listen for the Krakow sounds, in essence. They don't actually directly sense the pressure. What they're aware of is the pressure that the cuff is inflated to and where they hear the cutoffs. It's just like you're using the sphygmomanometer to do it yourself manually.
So they're acoustic. That's
Most
what
of them.
they're
Yeah, they're not pressure transducers, no. So, but if you work in the ICU, you get to work with our lines, which are really cool because they're very accurate as long as
Our
they're not
lines?
clotted. Arterial lines. So, that's about the only thing that ever goes into an artery. Where do all your IVs go? Veins, yeah. Which way do they face when you're putting the catheter in? Towards the heart. Good. Not everybody knows that. You'll be shocked. You'll be shocked. Do you ever administer drugs through an artery? Okay, good. Why not? Why do you think not? Other than probably knowing its policy. Why do you think physiologically you might not want to do that? Well, even if I've got an art line placed down here, why might it be a problem if I put drugs in there?
going directly.
To where? Where do the arteries go? Which way does the blood flow?
away from the heart.
So where is it going? So when it leaves, as you're putting that drug into an artery, where is it actually going next? As it goes,
Back.
well, what does it have to go through before it gets back to the heart? Oh, we're thinking much closer here. So if I'm using the radial artery here and I decide I'm going to put a drug in through my heart line, where's the blood going from here before it gets back to my heart? Where does it have to go through?
Yeah.
Doesn't that actually go like into my fingers?
Goes to the capillaries, right?
Do you know about let's see, what's the name of this exam? Before you place an art line, you occlude both of these arteries and you have them clinch.
Alan?
Allen, there we go. Yeah. So you look to see how quickly it pinks up, because you want to make sure that both of those are patent before you put a line in there that might occlude them. So what happens is if you're putting a drug in here and it's going from the artery down to the capillaries through the capillary bed and back, if it's something that's vasoactive, they might lose their hand. Because if it's a drug that causes everything to shut down, you may completely shut off circulation to all the tissue in the hand by putting a drug in an arterial line. It's weird, but when you put a drug in the vein, the vessels keep getting bigger all the way back to the heart. And that's why, like central lines and stuff are used where you've got drugs that need to be diluted like immediately, because that's where you have the greatest mixing, because central lines and stuff are supposed to start right at the superior vena cava, right at the entrance to the heart. So that's why. So anyway, back to this. So my priorities, when I'm figuring out my priorities, and there could be associated nursing diagnoses. I think I've got those here somewhere. Okay, ineffective airway clearance, right? Anxiety related to really fear of death, deficient. I didn't have that one in there, but deficient knowledge. So those are your nursing diagnoses. I'm not real big on nursing diagnosis, but your clinical instructors maybe. They will tell you what they want. I am big on you're able to figure out your priorities. I'm going to manage their O2. When I go into the room, I'm going to be listening to not only their effort, watching their effort, breathing, their color. I'm going to talk to them, see if they're getting from 1 to 3 words up to a sentence. If they're not confused, if they're moving forward, or if they're getting worse, because I may be wanting to call the doctor. So there's your concerns. This is a life-threatening level of asthma. Okay. Yeah.
So with the spider scribe, do we sign up and become a member or whatever, and then fill in the boxes, and it automatically populates the little arrows, or how does?
Yeah, it's actually it's drag and drop. It's very easy, and actually you'll find that you're really only working with. Sorry that I can't get this to resize appropriately. I'm not sure why. we'll try this one more time, but I don't think it's working for whatever reason.
Do we have to pay for a subscription?
No, you don't. You can do it for free. If you want, I actually pay the $5 a month because I want to be able to do public maps and do lots and lots of maps. I think on the free level, you can have three public maps. I think you're not limited to just, you can do lots of maps for yourself. And what you do when you're done with a map is you just invite me to come take a look at it. You say, it'll show you how, or, worst case scenario, you can always have it, you can ask it to print out like a graphic file and you can email that to me too. Last semester I really got tired of people drawing on paper and taking cameras, and it just turned out it was really awkward and hard for me to read. This is easier. Color coding and stuff like that, that's nice, but you don't have to work that hard at it. What I want is that you are able to tell me why the patient's there, what lab values and stuff, what was gathered in the history, what their orders are, what your concerns are, and what you're going to be looking for.
So how far in advance do you give us these scenarios? How far in advance before these are due?
I will hopefully get most of them actually up over the weekend.
So they'll be up, and then
You can do them at your
just
leisure.
do them whenever, and then they're due by whatever date. You just email what you do before class.
Yeah.
Okay. So when something's due on a day of class,
Typically it's due by 9 a.m.
okay, that's what I want.
before the first lecture.
Okay.
And speaking of lecture, if I don't get to this, we're not going to do it, and then I'll be behind and won't be a good day. Bad day in Black Rock. So, let's see how PowerPoint works. Hopefully I can resize that. Yes, open it with PowerPoint.
Yeah, so next week we're doing it.
Yeah, we'll actually walk through it together, and I'll figure out how to make this so we can actually understand what the heck we're doing here. Oh, stop it. Excuse me. I don't know what this is. That's interesting. And I didn't set it up that way. In theory, I had these set up so that you can actually play the notes as an audio file. It hasn't worked before. Why it's working today, I don't know. But anyway, I'll turn that off because it's really irritating to me. Let's try this again. So let's talk about infusion therapy. So what is infusion therapy? IVs? Who said that? Good. What do we infuse? Fluids, electrolytes, drugs, yeah. So, one of the primary goals of IV therapies is to prevent electrolyte imbalances and fluid imbalances. And so those are things that we do frequently in the hospitals. We give them fluid, or we give them drugs to remove fluid. How much do you think a person can, how much fluid weight do you think a patient can gain in the hospital?
How much fluid weight can they gain? How long are they there?
3 days.
It
Sepsis.
depend on,
It's a septic patient. The protocol for that is tons of fluid. How much do you think they might gain?
think about how much you can gain in a day, water weight, 3 pounds, 5 pounds.
I've seen 20 kilos.
In 3 days.
Oh, yeah. So what is 20 kilos, which is what, 20 liters? What's that going to do to your heart? To your lungs? Yeah, it's possible. So often patients that are septic, the reason they give them so many fluids is you typically trying to combat, they're not hypovolemic, but they're hypotensive. And they go through a vascular collapse. And so one of the solutions is pump a lot of fluid in because you want to keep things flowing. Yeah, we'll deal with the fluid overload later. If we can keep them alive, we'll get there. So, yeah, then you give them Lasix. And when you're giving them Lasix, what are you looking for? What's your concern with Lasix? Or furosemide? What particular ion does it affect that we probably all need? Many?
Potassium.
Potassium, yeah, good. What's the problem with too much potassium in the bloodstream? You have a K of 7. What might you see in that patient? Dysrhythmias. They have a K of 2. What might you see in that patient? Dysrhythmias. There we go. Okay, the Infusion Nurses Society. It's someplace. Where is it? It's back in Maine. And these are people who are dedicated to be basically the special of being infusion specialists. Cool. I don't belong to it. I belong to AACN, basically critical care nurses. So let's talk about tonicity. Any of you remember, like, from chemistry? What's something is isotonic? What does iso mean? Same. Okay. So what's something that is isotonic?
Same concentration.
Same tonicity, right. And tonicity just basically tells you whether or not the fluids basically are in balance with each other in terms of the diffused stuff in them. So what's hypertonic? What kind of a solution might be hypertonic?
Concentration?
Yeah. So like instead of NS, normal saline. What's the actual designation for normal saline? What's the percentage of saline? 0.9. Yeah. So if you give 1.8%, that's a hypertonic solution. The most common hypertonic solutions tend to be things like TPN. They often have at least 10% glucose in them, among other things. And what's hypotonic? Yeah, so what solution have any of you given any? Oh, you haven't given IVs yet. I forget. I'm sorry.
No, we started IVs last semester.
Okay, and while you were in the hospital, did you at least monitor any patients that were on drips? Did you have anybody that was on a hypotonic solution? What solution might you be looking for that would be hypotonic? Half NS, yes. P5, half NS. So the dextrose is balanced. Does the dextrose actually enter into your osmolarity? Actually, in a way, it doesn't. It's not. It's indirectly related. Anyway. Well, I ask all kinds of questions like, if you have a patient that has an albumin of 2.2, what do you think might be a problem for them? What does albumin tell you about their health status? So, and further, a broader perspective, it's an indicator of what in terms of their nutrition, right? Diet. Okay. So if they're deficient in their diet and they're not able to make albumin, albumin transports things that are hydrophobic, so it transports other chemicals, but it has one other major task. Not that you can give a task to a protein, but what else does it participate in as far as the blood is concerned that we care about? I think I heard. No, not oxygen, sorry. Not. Anybody else got a thought about what albumin does in the bloodstream?
It pulls water into the bloodstream. Fluid.
Give me that right answer in a different way. There's a word that goes with that. When you're managing the water balance, what are you doing? Osmolarity? Okay, so it's it really has a profound impact on the osmolarity of the blood. If you don't have much albumin, where's the water going to go? Into the tissue. And when you're assessing that patient, what are you going to find? Edema? Yeah. So somebody who has a very low albumin is going to have difficulty holding on to their fluid. That last year wasn't part of the lecture. That's a freebie. Okay. So these fluids that we give have different levels of tonicity. Somebody who's like been vomiting, you need to replace their fluids. Labor and delivery. Somebody who's had cranial trauma. All of these things actually will look at the tonicity of their. You're trying to manage their fluid levels. So hypotonic, like you all said, these are fluids that have a lower concentration than the blood. Hypertonic have a higher concentration than isotonic NASH. Hypertonic solutions are actually dangerous and often are high alert meds because you can kill people with them. Hypertonic solutions tend to make the blood more viscous, thicker, and they can also impact. The brain is very sensitive to the osmolarity of the blood, and so if you change the osmolarity, the brain may start expanding. And do we do well with big brains when our skull doesn't change size? No, it'll actually force it down and kill them. And it can happen like in a shift. It doesn't take long. So hypertonic solutions tend to be high alert drugs. So she comes in with she hasn't been able to drink. Do elderly patients have the same sense of thirst that you and I do? No, my mom doesn't. So how out of whack is that sodium? Is that a high sodium? Is it a really high sodium? Is it a dangerously high sodium? Yes. What symptoms do you think she might exhibit?
Thirst.
Confusion.
Probably not. Well, she might be thirsty, but not necessarily. Confusion, yes. So it often shows up because of the changes in electrolytes. The family will say, she's talking crazy and doing all this weird stuff. She doesn't usually do that. What do you think might be the underlying cause? Why do you think she might be dehydrated?
Well, she has C. diff, so she's diarrhea.
Oh, yeah. Do you think she has a UTI, maybe? Too? Probably. Yeah. Okay, good. You're all on the right track. Am I making you crazy? Okay, good. So you're going to give a gradual, you're going to gradually change that, because again, if they've actually been really hypertonic, if they come in with a sodium, hypernatremic, if you change that sodium level too fast, you will kill them. So if a doctor gives you an order, for that patient that has, the 155 and says, oh, let's start giving them, a bunch of, we're going to give them half NS right away. It's like, actually, that's not a safe order. You probably will not administer that drug. And hopefully you will call the doctor up and say, did you really want, you have to do this, you have to be politic about it, because you don't want to challenge them on their treatment protocols and their therapy, but you do have to say, I'm concerned for this patient's safety with that order. So, you'll probably talk to your colleagues and say, Dr. Jones says this all the time, but you will end up, hopefully, calling the doctor, or if you're working in a teaching hospital, talking to the resident and saying, I'm really concerned about this order, but, is that really what you intended? Oh, no, that's for moral. It happens. It does happen. So you can't just take those orders, just because they wrote them, doesn't mean they're right. And especially with the electronic records and stuff, it's check boxes. Check. And once you've seen what the doctors, the doctors, they do work hard. They have page after page of orders to fill out on a new admission. So, it's not trivial, and the opportunities for error slip in, which is why the expectation is that the pharmacist and the nurse And everybody in the chain will be looking at those orders to say, does that make sense for my patient? And before you give that, you want to make sure it makes sense for your patient. So, where am I here? That's slide 6. How did I get there? I am confused. We covered that. Oh, this is the guy I went to Death. I like Death Valley. It's one of my favorite places. I normally go in spring before it gets warm. I got into training some years ago and took my motorcycle. There was one of the groups I hang out with online was taking photographs of their bike with their GPS at the highest elevation that they'd been to with the bike. And I was down near Death Valley. I thought, well, okay, I'll go up into the the bristlecone pine forest and get up to over, it was like 13,000 feet. And I took my picture and I thought, it's only 100 miles to Badwater, which is 218 feet or 285 feet below sea level. I'll do that too. I should have done it the other way around. It was 123 in Death Valley. Riding a motorcycle in 120-degree weather is not actually pleasant. So I might have been like this guy, except I stopped every 10 minutes and downed, a quart of Gatorade. But when you're dehydrated, they need fluid. So you'll find that like people who come out of surgery, they'll often have lactated ringers running, LR, maybe saline, normal saline. You will find that surgeons order different fluids than medicine doctors order. They just have a different point of view, a different rationale. What's the difference between lactated ringers and normal saline?
Isn't lactated ringers a little more dangerous to give?
No, I'm aware of.
Does
Yeah.
it have like additives to it?
It's the electrolytes are
Yeah.
balanced. It matches the electrolytes in the blood, whereas normal saline is just. Anyway. So a lot of times, the surgeons look at that from the perspective of that because of the surgery, that their electrolytes are more likely to be deranged, so they're going to do something to help balance that out. So parenteral nutrition. Let's talk about this for a minute. You'll see it called parenteral nutrition, PN, TPN, PPN. And the difference between TPN and PPN is actually very important, and you don't want to miss this one on the exam. Okay? So, TPN, total parenteral nutrition, is always given through a central line because it has a glucose concentration of 10% or greater. It is hypertonic. It will irritate vessels. It will cause problems. So central lines, whether it's a PIC, which we'll talk about briefly in a minute, or like an intrajugular or a femoral line, those all ultimately end up with the catheter tip right at the heart, right at the superior vena cava.
So
And that's where
you said TPN is hypertonic?
Yes.
Okay.
So it's a concentrated solution. So when you get to the heart, that's where you have the greatest mixing going on, and so it dilutes it quickly. PPN is parenteral, peripheral parenteral nutrition. It is not so hypertonic. It's more isotonic to and therefore it can be given peripherally. It does not have to be given through a central line, but it's not as effective. I shouldn't say that. It's less invasive in a way because it's peripheral, but there's more issues that go along with that. So, they're not going to get the same, it's going to change the volumes, and, this is for somebody who's less nutritionally challenged than somebody that's on TPN.
And that's more isotonic than...
Yeah. It's not isotonic, but it's less than 10% on the glucose concentration. Mostly it's the glucose that causes the problem.
Less than 10%?
For PPN,
For PPN, and
Yeah.
the TPN is more than 10%.
10% or greater. And a lot of times with TPN, you'll actually find that they add insulin to it as well. So what do you have to have? What has to be on standby, or at least in the med room for you, for a patient that's on TPN? This is actually an NCLEX question. But not as an NCLEX style.
What do you need? What do you need to have in the med room? Give me a little more specific.
Their central line clots off and you're not able to administer TPN anymore.
Heparin.
See, my hint did help, did it? So you're giving somebody a continuous infusion of sugar.
Oh, you need some
Or
not insulin.
So what's the body doing in response to that sugar? It's
Yeah.
making a lot of insulin.
Making a lot of sugar, yeah.
So what happens if you suddenly stop the sugar? Does the body immediately stop making insulin? So what's going to happen to their blood sugar? Doesn't help. Because the insulin is going to continue to promote moving the sugar out of the blood and into the cells, and all of a sudden their blood sugar, instead of being 160, is going to be 50. They can potentially get very hypoglycemic. So what you have to have on standby is 10% glucose. D10 needs to be available, because if you have to stop that TPN, you need to keep the glucose running, at least until you can taper off. That's an NCLEX question.
Say that again. Glucose of
D10 generally is D10. So by D10, we're saying dextrose 10%.
And that's needed if there's.
Well, so if you suddenly have to stop the TPN for some reason, it ran out, the line's occluded, whatever. But they need to continue to get the sugar, especially if their TPN had insulin in it. It's all the more critical. You'll be amazed how quickly they can drop. And you're going to check that patient's blood sugar every 4 hours.
You couldn't just give them insulin. It has to be the.
Well, if they're so let's think about the physiology here.
So if they're low, they're low.
So do you give insulin when they're low?
No.
What do you give?
Sugar.
Sure. Yeah. When I was working up in South Sacramento, when they first went live with Health Connect, I was also assisting down in the ED down there. And they had a patient who the paramedics brought in, and she had been very hypoglycemic at home. They gave her insulin. She came in with a blood sugar of like 8. What would happen to you or me if I had a blood sugar of 8? What would it do to you? Probably kill you, actually. And almost certainly cause brain damage. Somehow she survived it, and the family said, oh yeah, that's, Mom, she's just fine. So yeah, it's giving insulin to somebody who's hypoglycemic is like, what planet are you from? TPN, the bags. What do you think those bags offer to the world that is dangerous to the patient? What's going to be good about TPN that's not good for the patient? I know that's a really random, it's kind of a really broad question. My degree was in bacteriology. Does that help? Is it a good medium? Yeah, it's great. So what happens, every 24 hours, you change everything out. They get a new bag every 24 hours, new line, because it's high risk for, it's a high risk, a high order drug. And usually, as I said, let's see where I'm at. That's 8, I should be an 8. Okay, so you have, both peripheral, IVs, which you guys are going to know about. You've all started one now, right? You've had that opportunity to talk with one of your classmates or something? Isn't that fun? I offered myself up. I'm uncommitted, and the poor student who did that is like, I'm bleeding. You gotta hold pressure. Yeah, you want to know if your patient's uncommitted when you are starting lines and stuff. We'll talk about TPA another time. And of course, central lines can be placed by numerous. Well, no, not really. What does PICC stand for? PICC. Peripherally inserted central catheter. So is it a central line? Yeah. It's a central catheter. It's just that it has been inserted peripherally. So they started here and it runs all the way to the heart. Who can do that? RNs, yes. Can RNs put internal jugulars in? No. Can they put a fem line? Yeah. No, those are doctors. So it depends on the kind, but they all accomplish the same thing. They put a catheter that runs straight to the heart. And you really don't want somebody on a central, you don't want somebody on like an IJ or a triple lumen for any longer than necessary because they are actually, they're a site for infection. And so blood infections are a big deal. How long can a PICC stay in place? Do you remember?
Was it a year?
That's a year. A midline is maximum of 6 weeks. And then peripherals are, depending on the facility, 72 to 96 hours. Or PRN, when you walk in and you see that it's oozing all over the next day. How often do you change the dressings?
When needed, or
like the central lines will probably be changed by, well, you'll eventually learn how to change central lines, but they're usually good for a week unless they become soiled. Same thing with PICCs. Your peripherals, it's PRN or, when you change out the catheter. But if there's blood stain or stuff like that, you're going to change them. So we're not going to talk about slide 9 so much, you've already done this. See, previously they didn't do this until this semester, and everyone's like, oh, I'm so nice. You see, you've already done it. You got past that. Great. Which also means that, well, I won't put words in the mouths of your instructors. That would not be fine. The clinical instructors would rather tell you themselves what their plans are. So, these are the most likely veins that you're going to use. Where do you start your first IV? I heard a voice. Go for it. Most distal, right. So you want to start as far away as you can and start working out because you want to preserve those other sites. Okay. And then, here's the thing. People that are healthy have veins. People that aren't, don't. Diabetics are horrible. Or you have a patient who's 350 pounds and edematous. Good luck finding a vein. I heard a comment.
No, I just said, and they're what?
Edematous.
Okay.
Edema. What's anasarca? Have you ever heard that term? Anasarca is a generalized edema to the point where they're blistering. This will be somebody with a oh yeah, you'll see it. Probably in the ICU, less likely on the floor. But somebody who's got an albumin, 2, and they're running fluids in, and they can't hold on to the fluids. So interestingly enough, somebody who can't hold on to the fluids while they are edematous and leaking through their skin is probably vascularly within the veins and arteries, they're actually dehydrated because they can't hold on to the fluid. So you're always giving them fluid to try and keep things moving. It's a challenge. Okay. I've only seen digital IVs a couple of times, people starting on the fingers. Because, I don't know about you, but even I have fairly small veins at that level. It's just a challenge. A lot of times you can use these veins, it depends on your patient and how their circulation is and how tortured the vein is. If the vein is doing this as opposed to that, that's a much tougher vein to work with. I also came to the conclusion that all of my elderly patients who'd walk in and you say, oh my God, look at those veins, they're huge, they're great. That, the veins had some kind of like a distance sensor, and you'd get the catheter about 3 millimeters away and it would go. So their veins, just like their skin, tend to be very delicate. So sometimes you have to start them like without a tourniquet, because just the additional pressure of the tourniquet is enough that when you hit it, it's like hitting a balloon with a needle. All those interesting challenges. Are there situations where you never place any kind of PIC or peripheral on an appendage? What are those situations in particular?
Paralysis of an arm.
Okay, so if they've got like a hemiplegia,
If they have edema.
nah, demon's not going to stop you. In fact, you'll be placing
What?
IVs when they have edema.
Yeah.
Mastectomy. A mastectomy.
Mastectomy, yes. What else?
Again,
Cellulitis.
You're going to avoid cellulitis sites because you've already got an infection going. Yeah, okay. But I'm thinking just sort of more
Burns, like burns.
burns. Okay, and I didn't hear what you said. Exactly. So if they've got a fistula for an AV fistula because they're on dialysis, you'll see a sign that says "Do not use the right arm." Blood pressures, IVs, blood draws, because they don't want anybody messing with those. Have any of you assessed a fistula yet? You have? Cool. What did it sound like? What did it feel like?
Yeah.
Weird. Yeah. Has a
When you
throb.
listen to it, you could hear like the like so clearly.
Right. Did you palpate it as well?
Mhm.
So how did it feel? You don't
It was
remember.
like one of the
It
first
actually
things.
kind of feels like it's rumbling or thrill. It has what's called a thrill because of the turbulence. I saw another hand go up over here a minute ago. Somebody else also had a
Oh
septic
yeah,
issue?
I saw one.
You saw.
Yeah.
Good. So, that's what we were talking about. So, as I said, there's 4 kinds. We have PICs, which are some, like when I was working, did I talk in this class about working in the outpatient IV pharmacy? Did I leave that out? After I left the ICU, I went and worked at Kaiser's outpatient IV pharmacy for 3 years in San Francisco. Those are the patients who are going to go home with a long-term IV. Long-term meaning 2 weeks to a year or permanent, whatever. How much does it cost to have a bed in the ICU before you start providing care to a patient? What's the daily cost for an ICU bed with no care at all? Anybody got a guess? Try 15 to 18,000 for the bed.
That's stupid. They're not even that comfortable.
Hmm?
They're probably not even that comfortable.
No, they're not. I guarantee you, they're not that comfortable. Kaiser, if you're a Medicare patient and you have exceeded your stay, from the physician's perspective, there's no more medically they can do for you, and you're saying, no, I'm not going to leave. They charge you pretty much, actually, I think what their base cost is. Do you know what that is? $5,000 a day. That usually helps motivate people to leave. So, if it's $5,000 a day for them to be in the hospital before they receive care, and their only reason to stay in the hospital is to get an IV twice a day, does it make sense for them to stay in the hospital for 6 weeks? No, you send them home. And you teach them how to self-administer ceftriaxone or whatever, TPN. So that was what I did. And the center I worked in, we managed 16 hospitals. We had about 2,000 patients at any one time, and I spent the day on the phone. So anyway, how did they get there? Oh, we're talking about kinds. So those people often went home with PICs, so they also had to learn how to maintain the PIC line and how to flush. There are non-tunneled, tunneled, and ports. So non-tunneled is like an internal jugular, and they placed it right here. They just cut down and went straight into the jugular vein, or they went for the femoral vein, and the line goes right in. A tunneled catheter means that they made an incision, and then they slipped it typically under the clavicle and into a vessel and into the heart. What do you think the risk associated with that particular procedure might be? Anybody want to guess before we run out of time? Puncturing? Puncturing what? what's here and here and runs down to here and up to here? Lungs? Yeah, they can do a pneumothorax. It's really easy to, go through the wall of the vessel and right into the lungs. So it's not an uncommon side effect. Bad side effect. So a tunneled catheter runs in that way. Non-tunneled, it's just direct access to the vein. And then there's vascular access ports. Ports are for people who are getting like chemo for the rest of their life or whatever. They actually, the device is actually subcutaneous. And again, make sure in your reading that you know the difference between a coring and a non-coring needle. Pretty much everybody misses the question on the test about coring and non-coring. So,
What is the difference?
a coring needle, when you put the needle in, takes a core. It leaves a hole. A non-coring needle does not leave a hole. And so you've got this port that has sort of like a silicone type membrane. You don't want to punch holes in it, because then they have to take the port out and replace it. And it's a surgical procedure. So you never use a coring needle. You'll always use a non-coring. So look for non-coring when you're reading questions. Don't get fooled by doing what I do, which is reading all of the question except the last 3 words. Okay. How many slides do we have here? Oh, we're getting close. Good. I might be able to run through this. I think we'll be okay. Oh, and there's rules about flushing PICCs. Typically they tell you it always must be a 10 cc syringe. And that's because of the hydraulics involved. But basic 10 cc syringes are always the same diameter. If you use a small diameter syringe on a PICC, you can rupture the line because it develops so much greater pressure. You can use a larger, and that won't cause any problem, but you may have trouble flushing it. And typically, you'll hear people talk about, they need a saline lock. Almost nobody uses, they need a HEP lock. Nobody uses heparin except in unusual cases anymore. The studies indicated it wasn't beneficial and it could actually trigger allergies as they're more susceptible to heparin-induced thrombocytopenia, HIT, which is really ugly, kills patients. So usually it's a saline lock, even if they say HEP lock. It'll be saline, which just means you flushed it, clamped it off, and walked away.
I remember the skills pretest you just had us do the one time that the patient has a vascular access port and the nurse is going to remove the needle from the port, which of the following would be correct. That would be one of the only times where you would flush it with the heparin.
Right, and how much heparin do you flush it with? Volume, I'm not talking units.
I have no idea, but I remember when we did this test before in our IV class that she said that was pretty much one of the only times that you would use that
So
during the flush.
you're not actually flushing it. What you're doing is instilling heparin to the exact same volume as what that port holds. Because you're not administering heparin to the patient. You don't have an order to administer heparin. What you have an order to do is to load that port, which has a cavity like 1.5 mils, with heparin so that it won't clot off. So what would happen if you came back a month later, accessed the port, and flushed it with saline? What are you doing? What happens to the patient? What do they get? They get heparin. So actually the first thing you do when you access that port is actually draw, because you have to take the heparin out. And then you flush. If you have a patient that's got a PICC, and it's clotted off, and the PICC nurse came by and administered TPA. What's TPA? Anybody know what TPA is? Streptokinase?
Dissolves clots.
Or clot busters, right. You don't actually want to give that to the patient. They give them just enough for the catheter because they want to break that clot down. So the first thing you do is you actually withdraw. Because if you flush, you just gave the patient TPA. And every wound that they have over the last several weeks will start weeping. And if they had a cerebral bleed, if they had a CVA with a bleed, you could kill them because it'll start rebleeding. I shouldn't keep saying you guys are going to kill patients. I know you're not. Okay, so these are a PICC, as I said earlier. starts, usually down here, sometimes up higher, and it runs all the way up, and then to the superior vena cava. And this is just what you'll see in terms of dressing. It's got that little donut. Actually, usually you don't put it through. You just lay that on top. It has a blue and a white surface. The blue faces up, and it's basically, it's treated with antibiotics. And a power pick is different from a regular pick in that a power pick has a port that is able to withstand the pressures that they use if somebody goes down for a CT scan and they're injecting dye. They have a power injector. So they either have to have a really good 20 gauge or bigger IV, or they have to have a power pick. Because otherwise, if they put that infuser on a non-power pick port, it will destroy the pick. And then they have to reinsert the pick, and everybody's
Is there
unhappy.
any other names for power pick? Or
No, power pick is patented.
I thought I remember.
You'll hear it. Non-tunneled, as I said, goes like directly into the femoral or jugular vein, straight up. These also get flushed with. They always get flushed with 10 mLs of normal saline. And here we're flushing. Tunneled catheter, like I said, it goes infuse you through the subclavian, and so it doesn't have to travel as far. And one of the advantages, the thought is that it's a little less susceptible to infection. I don't know if that's true or not.
And can you give an example of what
Why?
who would have a tunnel catheter?
Surgeon's choice.
This is sort of a
Depends on, some doctors like tunneled, some doctors like not tunneled. If you're working in a teaching hospital and the resident that day wants practice with a tunneled, they get a tunneled. And if they want practice with an IJ, they get an IJ. We're running out of time, so I won't tell you my IJ stories. And then, like I said, an implanted port, this thing is actually completely hidden. It's a lump under the skin, and you access it by palpation. This is the non-coring needle. So remember this for the test, the quiz, whatever. You always use a non-coring Huber needle on a port. And so, like you see at the port, it looks like a little, looks like a little pubis almost. Just a little bulge. And you'll often find patients in the hospital, nobody has charted that they have a port. You're doing an assessment, it's like, oh my goodness, he's got a port. It's not in the chart, so you get to have that. Because typically in the hospital they don't use the ports, because usually that patient had a port because they've got cancer or they've got chemo or whatever, and it's actually being used elsewhere. So they'll put another central line in rather than use the port. PCAs, we're over here, 22. Oh, good. We're gonna do just fine. What does PCA stand for? Oh, it's up there. Gee, that was an easy one. Okay, so have any of you had a patient on PCA yet? Do you push the button?
No.
Does the family push the button? Good. What happens if the patient pushes the button too many times? It won't deliver, right? So in your charting at the end of the day, you actually look at the number of attempts versus the number of deliveries. Now, if somebody is pushing it 20 times an hour, is that telling you something? What is it telling you? Tell me your name.
Christine.
Hi, Christine.
Maybe the pain isn't alleviated.
Maybe it's not controlled, yeah. They're like, okay. Depending on the facility, you may or may not get to administer drugs by IV push. Unfortunately for my group at Sutter, they just instituted a policy that says students other than seniors may not get any IV push drugs. So it's like, okay, we're going to go into practice and have never done an IV push. Good plan. Anyway, there is a technique to pushing drugs, which is different from it. I still remember one of the discharge planners telling my patient who was going home, oh, it's just like you flush. So anybody remember what the technique is for a flush? How do you actually administer the saline? It's pulsed. You pump, 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 pump. Because you're trying to make sure you blow off anything that's accumulating. If it's a drug, it's metered. It'll be like 1 ml per minute. Depends on the drug. It'll be, and actually, like in the drug information, will tell you what the administration rate for IV push is. Administer over 5 minutes. That means you stand there and watch the clock for 5 minutes. And usually, if you're given like 5 mLs, you give an ml and you wait a minute. You don't try and gradually over 5 minutes get the syringe because you'll go insane. Told the patient. Infiltration. What does infiltration mean? We're down to the last minute and a half. We're going to make it.
You blew like the vein.
Yeah, it's It's undergone extravasation. It's no longer in the vein, right? So what's the hint? Look at that arm. It may be cool to the touch, blanched, painful. Depends on whether the patient's conscious or not. Let me tell you, somebody started an IV on me once and it was outside the vein and they went to flush it and I almost hit the moon. It was like, that hurts. Don't do that. And then, what is phlebitis? What's an itis? Inflammation, not infection. Infection will have an itis associated because it's inflammatory. So what's a phleb? The veins. Phlebotomists, what do? They draw blood. So it's an inflamed vein. And things like TPN, potassium, lots of drugs will cause phlebitis. And class ends now, right? 90? No, we have another 10 minutes, right? 5 minutes?
9:25 to 11:40.
Oh, then we're done. Any last second burning desires, questions? Have I left you
So do
totally
we have a
confused?
quiz before next class? Or no?
I mean, based on reading?
Based on today's reading?
No, actually, I don't know yet.
Okay, so you'll send us an email. Gotcha.
I like the news forum thing because I can email everybody all at once. I will come to a conclusion about that. I have to give 10, my plan is to give 10 over the course of the semester. Thank you. Pleasure to meet you all.